Welcome to the first webinar of Haag-Streit Biometry Focus Month webinar series. Our topic today, as Sam mentioned, is how to utilize Eyestar comprehensive measurements to optimize IOL selection. Our objective is to show how Eyestar supports us taking safe and better decisions. Most of you knows me. My name is Abdo Jamal. As Sam mentioned, I'm the Market and Product Application Manager for Biometry at Haag-Streit. Please feel free to contact me for any issue about biometry you might have. So we will start our talk today with an overview about Eyestar Cataract Suite and the dataset that it provides. This will help us understand how to use these data in optimizing IOL selection. Then I will show few real cases to gain a clearer understanding. And finally, we will have some time for questions and answers. Just before I start, I would like to draw your attention that it is equally important to understand the patient's lifestyle and the optical quality of the eye before selecting the right IOL. Here today, we will only cover the optical evaluation of the eye. So what is Eyestar? It is a fully automated swept source OCT eye analyzer. When I say fully automated, I mean the device detects the eye, measures, and shows the result in fully automated manner. The data provided are used for anterior segment assessment and better planning for cataract and refractive surgery. High-quality biometry data are essential for making right decision. We at Haag-Streit believe that everything starts from data collection. Eyestar uses Mandela scanning pattern, and this pattern is not like most other devices that uses conventional radial scanning. Eyestar with Mandela scan pattern has better corneal coverage than radial scan. The data between the lines in radial scan are all interpreted or estimated. So we are comparing this corneal coverage with this. It is clear scan pattern matters. With Mandela scanning, we have high general density, central and peripheral. The collected data are then automatically validated and used to produce OCT images, corneal topography, and biometry measurements. An IOL calculation module is also part of the device. The swept source OCT technology allows us to construct OCT images in high speed with high resolution and, of course, long range. The corneal topography is also derived from the OCT data, and it meets the International Corneal Topography Standard. It covers the anterior and posterior sides of the cornea. Also, the corneal thickness is measured. All the maps are available in Eyestar, starting from anterior axial curvature to anterior elevation, anterior torical elevation, anterior tangential. Then at the posterior side, we have posterior axial curvature, posterior elevation, pachymetry map, and posterior tangential curvature. Zernike analysis or corneal aberrometer are included. This helps us identify corneal irregularities and support in treatment option selection. We use the Zernike data to build vision simulation that helps us understanding and explaining the current vision status to the patient. And also, we demonstrate the anticipated vision post-surgery. At this stage, with vision simulation, we can discuss with the patient different treatment options and involve the patient in IOL selection process, where surgeons are able to set the right expectations. Moving to biometry, entire eye is measured in one scan, which means higher precision. We can also superimpose A scan on B scan to check the gate's location, and in rare cases, we can correct the gates manually, and this is a possible option. Like the Eyestar, Eyestar uses dual zone reflective case. And also topography sim case are part of the package. So Eyestar has both reflective and simulated case. Reflective case perform better than sim case with IOL calculation. In addition to that, all-in-one comprehensive IOL platform is integrated in the Eyestar 900 to simplify IOL selection for any patient, including toric or post-refractive cases. A wide set or range of IOL formulae are available for monofocal, and the same applies for toric selection. We also have a toric planner that enables surgeon to change the proposed plan according to their need or convenience. For post-refractive, more data are need to be added. At least we need to know the pre-operative eye condition, myopic or hyperopic, what refractive procedure was done, and it's always better if we have the complete history data. Then Eyestar is equipped with the latest post-refractive formulae suite as a standard. Now, let's shift our focus to optimizing IOL selection. As you know, premium IOLs made cataract surgery a refractive procedure. It is crucial to use high-quality biometric data to safely decide which IOL is right for who. But before we dive into IOL selection, let's check the widely accepted criteria for premium IOL patient selection. So we should consider high lens tilt or decentration, higher order aberration, dry eye or excessive tears, corneal opacity or corneal pathologies, and if any previous corneal surgery was done. So let's have a quick look on lens tilt. In ideal eyes, the visual axis and the optical axis are on top of each other. But if the lens is tilted, then an angle between the visual axis and the optical axis is formed. Usually in normal eyes, this angle should be less than 5 degrees. The lower the tilt is, of course, the better. Eyestar measures the maximum tilt and show the orientation of the tilt. And I will show you later on the benefit of these data. Because lens tilt was not measured before, decentration was used to represent lens tilt. So angle alpha is the distance between visual center and corneal center, and the same applies for angle kappa, which is the distance between visual center and pupil center. The value in normal eyes will be less than 0.5 millimeter. Eyestar shows the decentration in X and Y coordinate. Chord alpha and chord mu are another way to represent decentration. But here we measure these values from the OCT image, where with angle alpha and angle kappa, we measure these from the infrared camera image. So this is only the difference between two. Anything else is exactly the same. And Eyestar is the only biometer that measures these chords. And for the chords, anything below 0.4 or 0.42 millimeter considered to be normal. The chords value are also available on Eyestar as a standard. So if the lens is tilted, that means the implanted IOL will be tilted as well. This has several implications on visual outcome after cataract surgery, like the lens tilt will induce astigmatism, it will cause glare or halos or reduced contrast sensitivity, it will introduce some high-order aberration and reduce visual acuity. Toric IOL may not align properly in some cases, and in rare cases, the tilted IOL may be less stable over time. So looking at the most common used IOLs for cataract surgery, how to decide which IOL should be used and when? Always monofocal IOLs are safe option in any situation. Of course, monofocal IOLs will have same implication if they are tilted. But we have to consider that the patient has a cataract that must be removed and the IOL should be implanted. So the safest option in this case is monofocal IOL. Multifocal IOLs are very sensitive to lens tilt and decentration. So we check lens tilt and decentration. And if the lens tilt and decentration, I mean chord alpha and chord mu and angle alpha or angle kappa, are in the accepted range, then the visual center will be in the IOL central optical zone. So the patient is multifocal IOL candidate in this case. When the lens tilt and the decentration don't comply with the accepted tolerance, that means the visual center will fall outside of the IOL central optical zone. This means multifocal is not an option for this patient. Moving to the toric IOLs, here we need more data about the cornea and the surgical plan. So topography is essential. We use the topography to evaluate if the astigmatism is regular or irregular, symmetric or asymmetric. We also have to check if the reflective case and the simulated case have a consent. Then we set our incision size and location. And finally, we have to consider our surgical induced astigmatism. Toric IOLs are not an option for irregular astigmatic cornea. So we exclude toric IOLs if we have irregular astigmatism. For regular symmetric astigmatic corneas, toric IOLs are optimal. Regular but asymmetric astigmatic corneas need further investigations and more discussion with the patient. So the perfect candidate for toric IOLs are regular symmetric astigmatic eyes. Another important aspect for premium IOL selection is higher order aberration. Aberrations cause distortion to our vision. It might be mild or sometimes severe. Corneal aberration are divided into two main categories. Majority of the corneal aberration is lower order aberration, and the rest is higher order aberration. And of course, from these two main categories, we have more categories for or more things about order aberration. So the lower order aberration can be treated with cataract surgery, especially with the use of premium IOLs. Where this doesn't apply for high order aberration, except the spherical aberration to a certain extent. High order aberration values cause vision distortion. Using premium IOLs will make the situation worse. So we must check higher order aberration before selecting a premium IOL. If the high order aberration values are low, then using premium IOLs is an option. But if the high order aberration values are high, especially if we look at the coma, then premium IOLs are not recommended and monofocal should be our only option. So with Eyestar, your results are accurate, reliable, validated, and complete. Eyestar comprehensive measurements provide confidence for better outcome. I will move now to show some demo cases where I can demonstrate how to use these measurements in real life. So this is the iSuite, the software that runs the Eyestar, how it look like. So first, I will show an overview about the measurements that we have with the Eyestar. So this is an overview for both eyes, and it's helpful to have, let's say, a quick look and compare if there is symmetry between both eyes. Then if I need more data about the eye or about the measurements, I click anywhere, and then I can dig further to investigate about the eye condition or the optical quality. So here for topography, as I showed you, we have all the maps for the anterior and the same for the posterior plus pachymetry map. Lens tilt, it shows the lens tilt, the chord, and where is the lens tilt axis. Then from white to white, I can also check the decentration, the angle alpha and the angle kappa. A-B scan, I see the A scan and the B scan, and then I can superimpose the A scan on top of the B scan. Finally, the Zernike analysis, I have an idea about the aberration, the vision simulation, and also it shows the corneal topography. Now I will show you when to check the gates and how to change the gates, which is also an important. So here I have a case where the patient has ICL implanted, and if we superimpose the A scan on top of the B scan, we can see the software detects the front of the ICL as the front of the lens. Here it's very easy. Then I move the gate to the right place and I say save, and everything now back in place, and I can continue the measurements. Then another case where I can use the software to better educate or explain to the patient the situation. Here I have a nice astigmatic cornea where I can explain to the patient that you have a regular symmetric astigmatism. In your case, it's optimal for toric IOL. And here the patient might accept or might not accept. But whenever I show him, this is your current vision because of the astigmatism in your cornea. And if we implant a toric IOL, this will be your vision. It's easier to explain the situation. Now, I show a case of higher order aberration where I can see with the Zernike analysis, if I implant a toric IOL, the situation will not improve. So here, there is no advantages of implanting a premium IOL. Finally, I would like to show a case where I have an eyes with the rules astigmatism, regular, and symmetric. It's a good candidate for toric IOLs. But if I look at the lens tilt, here the patient has a high lens tilt and high decentration. So what could be my options in this? I would say conservative approach would be to go with a monofocal IOL. But some doctors would like to improve the quality of life for this patient. Can Eyestar help them taking a better decision? So let's have a deeper look. If we look at the astigmatism, it is vertical. If we look at the lens tilt, the maximum tilt, which is 6 degrees, it's on the horizontal meridian. Now, if I go to see the A scan, this scan represents the horizontal plane. And if I move my cut to the vertical plane, I see the lens tilt is at the minimum level. So at the vertical, the lens tilt is minimum and my astigmatism is on the vertical. So this puts me in a better position to take maybe a toric implantation decision. I won't say you can, it's a must, but it gives me more confidence to say yes or no. It's more data to help me take a better decision. So these are more or less the cases that I would like to show. So with Eyestar, you can discuss all the details with your patients, set the right expectation, and you have confidence for better outcome. I would like to thank you for sparing time from your busy schedule to attend this webinar.